We really begun to look at, through our model at UNC Hospitals, which is a clinical specialist-based, service-based coverage model. How effectively are we utilizing our resources, and why are they applied with why they are positioned with this particular services? So there's a lot of questions that were asked amongst, are we utilizing our resources most efficiently? Are we positioning them to take care of the most sick patients? Are we ensuring that our resources, even new resources when applied, will they go ahead and be applied into the best place for the patient care? What we did was, working with our clinical specialists, we identified about 40 or 50 key performance indicators. We distilled those indicators down to about 5 that we felt were the most meaningful, that helped really articulate and objectively define how resources are applied. Those included census of the particular unit or service that we're covering, acuity, which I'll explain in a minute, teaching, how involved our students and residents are, the time involved in teaching them on those particular services, cost or drug spend on that particular service, and high-risk medications. I think the crux of the PCATCH model, as we call it, centers around acuity. What's the objective measure of how much pharmacy resources are poured into a particular patient population based off of MSDRGs? And what we found is a correlation between the service provided, the pharmacist positioned, and how sick those patients were. And so we looked to try to objectify that. And so, combining the C, the A, the T, the C, and the H, we came up with a PCATCH score for particular services with, in the acuity metric, a service-specific intensity score. Service-specific intensity score allows us really to drill down and understand how acute those patients are and whether it really makes sense to have a pharmacist. And what we did was, at our institution, we validated our model. We validated the positioning of those resources to ensure that they are taking care of the most sick patients based off of MSDRG and service-specific pharmacy intensity scores, as well as high-risk meds, on top of the other 3 metrics. But what that really did was that really positioned us to establish and say, objectively, it makes sense, our pharmacists are positioned in this spot. It also allowed us, for future allocations of resources, to apply them in an objective way. It moved the conversation from opinion to objective facts and measures to say, specifically, this is exactly where a pharmacist should be positioned because this is the PCATCH score associated with that service. So it's been a good model for us over the past couple of years. It's been validated, and regardless of whether you're a service-specific institution or a location-based institution, PCATCH can work for you. It could also work for you if you're a smaller community hospital as well as an academic center. There's a lot more research that's needed, though. I think we've just begun to scratch the surface to try to understand really where the positioning of pharmacists are best. PCATCH isn't the answer for everything, but it really, I think, begins to allow people to objectively assess where resources are positioned and a tool for them to use moving forward, the allocation of new resources should they receive them.